Hi, my name is Gustavo Vinagre, and I'm here to talk to you about the ACL reconstruction options. When you have an ACL tear in your knee and you want to reconstruct it, you have to know the different options you have and your surgeon have. So you have to know which one it fits better for you. So let's see, the first main concept is there is some differences between the autografts and the allografts. The autografts are tissue for your own body, it's your own tissue, so it is different from the allografts, that is tissue from usually a cadaver. So the main advantages are the BTB or the BPTB, the bone patellar tendon, is that is a bone-to-bone healing fixation in both tunnels. It is a better objective stability and allows a stronger rehab. It is an increased graft size and width, and there is a decreased graft laxity. There is a comparable stiffness to native ACL and due to the fixation strength. It is easy to harvest. It is easy to revise at the second revision surgery because of the bone plugs if there is no metal screw fixation. It is an older technique with excellent results. It is used in high demand and high performance athletes as soccer players, basketball, martial arts, sprinters, gymnasts, or dancers. And it is used also in revision surgery after hamstrings grafts, and as main disadvantages is not suitable for double bundle reconstruction. There is a small ligament cross section because there is flat. There is a risk of anterior knee and there is kneeling pain. There is the risk of patellar fracture, patellar tendinitis, patellar tendon avulsion or rupture, patellar chondropathy, patellar medial or lateral subluxation, or even tibial stress fracture when you harvest the tibial side of the bone plug. Of course, there is harvest morbidity, and there is a larger incision to be considered. So an alternative you have like to have two transverse incisions, either on the patella or in the tibial tuberosity, and there is a fixed and predetermined graft length, and it can be a graft mismatch because each own graft has its own size and length. So it can give also a loss of extension and some lateral knee hypoesthesia because of the sural nerve that passes through the patellar tendon. It is weaker than the native ACL, and is contraindicated if there is kneeling activities, patellar tendinitis, a larger ossicle, a patella alta or baja, an open physis, and as in an immature patient, and a previous graft harvest less than 2 years ago. Okay, so let's move on to the hamstrings autograft. Is a very widely used autograft. It is easy because it is easy to harvest. There is no anterior knee pain as in the BTB. There is a large sectional area size. There is a smaller incision, so it is more cosmetic. It is a lower donor side morbidity. It has a comparable strength to the native ACL. There is a fast graft acquisition. It is faster to acquire, and there is easy graft passage through both tunnels. There is the preservation of the femoral patellar complex, and there is less risk of cyclops syndrome when you flex or extend your knee. The graft can be customized or individualized in length and diameter, and it can be used in patellar chondropathy, patellar pain, elderly patients, patients with kneeling activities, patients involving in jumping activities with some static concerns, in revision surgery after the BTB reconstruction, and in higher performance athletes with patellar misalignment. It can be used like two semi-Ts, each one of each knee, to avoid the muscle residual tears. So in disadvantages, we can see that there is a more difficult graft fixation because it's tendon to bone and not bone to bone. So it is a prolonged osseointegration of the graft. There is a soft tissue healing, and it can give hematoma inside the knee. The graft size is unpredictable because it depends on the size of the hamstrings of your own hamstrings. There is a complex graft preparation after the harvest of those. There is a decreased flexion strength. There is a weakening of the ACL agonists because they are ACL agonists, so they are weakened. So there is a decrease in the internal rotation strength, and it is very important to the athletes. The graft is more lax, and in the KT 1000 there are more laxity. The tunnels can be widened in time, and that can be a saphenous nerve injury when you harvest the hamstrings. It is not suitable for certain athletes who rely on their hamstring muscles because it can give medial instability, and there is less stiffness than the native ACL. There is a risk of residual muscle tearing in the biceps femoris and semimembranosus. So let's see now the quadriceps tendon autograft. There is a very versatile graft because it's thicker, and it can be used for a single bundle or a double bundle reconstruction with or without the one side bone block used in the quadriceps tendon autograft. So it is a lower donor side morbidity, less than the BTB. It is used in failed ACL, is widely used in failed ACL reconstruction, in the second ACL reconstruction, in low patella or patellachondropathy and tendinopathy. So mainly disadvantages is there is an invasive and larger incision, and it can give an anesthetic scar. The quadriceps muscle weakness, the risk of patellar fracture, as well as in the BTB graft. There is a larger incision. It can be a worse cosmesis. There is a long graft harvest time, and the suprapatellar pouch is open. So, and it is not suitable for obese patients because of the fat tendon degeneration. Well, the last graft we can use is the allograft. As I said before, there are grafts that are provided by the cadaver. So you can have a patellar tendon, an Achilles tendon, a quadriceps tendon, a semi-T, a gracilis, a tibialis anterior, and a posterior tibialis too. So as advantage, you don't have donor side morbidity, and you have a lesser postoperative pain. It is available in various types and sizes. It depends on the donor tissue you have. It is a shorter operative time, decreased operative time, and the graft preparation is less too. So it is widely used in failed ACL reconstruction, in revision ACL reconstruction, and the main disadvantage is that is a risk of disease transmission of infectious disease. Of course, it's less if no bone block is used. There is a slower ligamentization, a longer healing time, and the graft is more lax. And there are described more high failure rates, an increased risk of re-rupture, especially in young and active patients with high demand sports activities, and in irradiated grafts, mainly used in the US because of the risk of disease transmission. Of course, the problem of the donor availability. Each cadaver can provide for example, BTBs. Can provide other tendons too, and it is more expensive too. So it is a thing to have in account too. So we have summarized, we have reviewed all the or almost all the grafts used in the ACL reconstruction surgery. So I hope you like it. I hope you are more informed and you can have a talk with your surgeon to get the best option for your knee and for yourself. So I hope you like it and see you next time. Bye.